back right there, good. And just to make sure that they're comfortable and they know they're not gonna fall off, they can have their body a little bit more on the table, but just making sure those hips are as far back as possible so that you can actually get the leg into the necessary range of motion. Can I be straighten your legs out just a little bit? So I'm gonna have her, straighten her hips. There you go. So you're actually gonna have your patient start, they don't need to be fully straight, but it's gonna be the same setting of the pelvis where you wanna get them into that neutral lumbar flexion. So same method where you're gonna find L4, L5. So finding that iliac crest, coming back, palpating those spinous processes. I'm gonna keep one finger on L4, one finger on L5, and then I'm actually gonna lift her lower extremities. And I would lower the table. Again, we don't have the high lows, but just thinking about body mechanics, trying to lower the table a little bit. And I'm gonna have you flex your knees and let me push you up. Please stop biting me. Sorry. So you're gonna flex the hips up. Let's try that this way. Relax.
Okay.
There we go. So
Close your eyes.
just relax. So again, bring her hips flexed up until you start to feel L5 move, not L4. That'll be the same starting position for your initial testing, retesting, clinically speaking. So now I have her in the starting test position. The other thing you want to make sure is that her hips are stacked on each other. You want to make sure she's not externally rotated or forward rotated. I mean, it's more like right and left rotation, but that her hips aren't facing the ceiling. They're not pointing down to the ground because that will affect how you're measuring. So making sure those hips are stacked and then stabilizing at the pelvis. You want to make sure you're not blocking off that TFL muscle because this is an MLT for the tensor fasciae lata and IT band, but making sure that when you're doing this test, you're not going to get contralateral pelvic tilt, and I'll show you what I'm talking about in a second. So the next thing, what does the TFL do? Or sorry, your TFL and IT band.
Internal rotation.
They internally rotate.
AB duct.
AB duct, hip flexion. So I'm going to make sure, one thing, again, this is why I would have the table lower, is because I want to make sure you can easily, and a lot of people will do this, the compensation would be hip internal rotation. And that happens if her ankle is above her knee. So you want to make sure it's even so that her knee and her ankle are in the same plane so that you're in neutral hip internal external rotation. Does that make sense to everybody?
Yeah.
So then I'm going to AB duct, and then I'm going to extend, making sure that she's not rolling those hips. Bless you. And I'm going to extend into about 10 degrees of hip extension, but once you set the pelvis, that's just in line with the body. So that's another reason why you set the pelvis, because then you know you're in about 10 degrees, but it's just going to be neutral. And you want to make sure you're not bringing them too far back, because if they have tight hip flexors, you can get excessive lumbar lordosis. And then we'll also talk about modified Ober in a second, where if they can't get into this position, you'll straighten the leg. We'll talk about that. So again, you're going to AB duct, making sure that, and the way you can kind of tell that her leg is neutral is my forearm is also going to be in that straight level plane. Does that make sense? Okay. Please relax.
Trying.
So coming back, and then normal is that you're able to slowly lower that leg to 10 degrees below horizontal. So feeling for that first resistance, coming down. I'm starting to feel resistance about here. And then you can have somebody in the clinic, you can have somebody looking at it, or somebody else holding the goni. We don't have inclinometers, but that's, I don't know if you guys have seen those. Those are the angle ones. This one, I think we usually just eyeball, or do we have them take a measurement? Eyeball. We eyeball, okay. So bringing them back, coming down, and then you can move your hand back a little bit, making sure that you're not dropping her into internal rotation, and just looking. She's even, maybe 5 degrees, so I should say she has about 5 degrees of tightness there. Does that make sense? When you're moving that hand, just make sure that you're still supporting that leg, not letting her come into that internal rotation. So that's the Ober test. Now, the modified Ober test is where same position, same setup, but I'm gonna have her straighten her leg. Why would I need to have her straighten her leg?
Reducible tightness of the right thumb.
Yeah, because if she has tightness in the rec fem and you can't get her into that extension, it's going to affect the test. So you will need to make a note on your documentation in clinic if you did Ober versus modified Ober, so that you can repeat the correct test, or maybe they're tight in both these structures and you're also working on rec fem flexibility, and then later you can get to the regular Ober test. You'd want to make a note of that they were a different test. So things for documentation and clinical application. So the modified Ober test, straight leg, relax. Same test though, same, you still want her 10 degrees below the horizontal. So I'm still gonna stabilize that pelvis, make sure she's not rolling forward or backward. I'm coming back into about that 10 degrees of extension. And again, lowering her until I feel that first resistance. And it should also be that 10 degrees of a deduction below the horizontal. Questions on that one? It's a little more straightforward.
No, just making sure pelvis is stable, lumbar spine is in neutral. Also making sure the hips stay stacked.
Yep.
That would be the other one. With all of the side lying tests that we do, I would say usually 50% of you don't do that on the practical.
So for Ober, modified, and standard, the two biggest compensations that you'll see is that the pelvis starts to roll back and that the hip starts to internally rotate. So those are the two you're probably gonna need to make sure you're watching for the most. Questions, comments, concerns? All right, let's practice those.